2, so I apologize for the Swiss people. The train starts a little bit earlier. My name is Bruno Vande. I'm a radiologist in Brussels, just doing MSK radiology. And we will spend about 1 hour on metabolic bone disorders. There are many cases on your PC. I will not use the PC during the lecture, okay? Because we will interact, and I'm obliged to stay here for a while because I want to take some picture. Otherwise, I will go down with you because this room is terrible. It's huge, it's empty, you know, it's not easy. Are there any rheumatologists in the room or orthopedists? It doesn't look like, so we are all radiologists. That's great. So it's a lecture which is given by a stupid radiologist for stupid radiologists as well. So we will try to make it as simple as possible. And just to start, I will ask you a question. When you went at the ECR quite recently, what was the least attended session that you have ever seen? Was it knee MR imaging or tendon tears, FAI, or metabolic bone diseases? I think C is the best. For those who want to use the mobile, you can use it, but just raising your hand if you like. I don't use the voting system either. So it's definitely C. However, in your everyday practice, what is the most frequent disorder you are facing in your everyday practice? Could be meniscal tear, tendinous tear, or osteoporosis, or hip replacement. It's unfortunately C, osteoporosis. So we have to face the issue of metabolic bone diseases. And there is a major argument. This is this one. This is the number of births, and you know the baby boomers after the Second War, a large increase in number of births. If you combine that increase, and you can see that within a few years, they will all have more than 65 years of age. If you combine that curve with this one, which is the increase in life expectancy from the 1950s to now, we started at 61 and we're now about 85. So if you combine the life expectancy and the increase of births after the war, there is a huge amount of elderly patients having metabolic bone diseases, okay? So we will become geriatric radiologists, unfortunately, okay? We have to face the issue. So when you face metabolic bone diseases, there are many different conditions. They may involve the muscles, they may involve the tendon, the cartilage, the synovium. We will not describe these conditions in this lecture. We will focus on bone diseases, and even marrow disease will not be included. So we will focus on a small part of the entire series of complex metabolic bone disorders, right? Now, there are a few objectives that we need to reach. The first one is to remind you a little bit of bone physiology, because there are several points that have to be known. And then we will focus a little bit on the different diseases that we encounter in our practice. And as it is the main task for the radiologist, we will focus on the detection of fracture and finally of their complications. So I will not go into details in many conditions, including those who include increased bone density. We will not see all these techniques that are used, neither information on epidemiology and genetics. There are huge progress in this science to understand the disorders that we are facing. Forget about that. It's not extremely important for our practice. A point which is important and which is not part of this lecture is the differential diagnosis between a spontaneous benign fracture that we will see and those which are related to an underlying abnormal condition like a cancer. We will not see that challenge that we have occasionally in our practice. So by the end of this lecture, I'd like you to remember a few basic points on bone physiology and metabolic bone disorders. But we will focus on fractures, their detection, the comprehension of the images, and their complication. Is that all right? No problem? Okay, now, I leave the place because it's boring for me to be there. Now, there are very important basic knowledge that we need to have. And here, as an X-ray of a piece of bone, there are two bone components, two different sort of bones. Which are these? Yes? The cortical bone and cancellous bone or trabecular bone. These are totally different in many respects. And if I pay some time on that, it's because it's important for the rest of the lecture. The cortex is very thick. The trabecular bone, the spongiosa, the cancellous, all these terms are the same as a totally different bone. Now this is a young girl. This is the first case. She has a low BMI, not many kilograms, and she does a lot of dancing. And she comes with a problem in her foot. And this is an X-ray, and I know it's a fracture of the second metatarsal bone. I'll ask you, which type of bone is mainly concerned in that fracture? Cortical bone, okay? She came later, 3 months later. There is another fracture. Which type of bone is involved over there? You see, there is deformity. A little bit of cortical bone, but mainly the trabecular bone. And I show you the CT. This is the corresponding sagittal reformat of that cortical fracture. And look over here. Although there is a small cortex, you see it's completely flattened. The trabecular bone, the spongiosa, has been compressed. There is deformity, and there is callus formation with sclerosis if you compare with the adjacent metatarsal head, which is normal, okay? These are two different types of fracture. Basically, there is always some cortical bone and trabecular bone, but this is a predominantly cortical fracture, and that's predominantly a trabecular fracture. We'll be back to that later. It's very, very important to remember. Now, the cortex is very compact. It has only a biomechanical role. There are no change at the surfaces with take in and take out of calcium or phosphor. It's a huge amount of the skeleton, but there is a very limited amount of surface available to the different cells. It is opposite in the cancellous bone. Only 20% of the skeleton is made of trabecular bone, but there is a huge amount of surface on which the cells are present, and that's where the exchange with the blood, the environment are possible. So the biomechanical, there is no biomechanical role here. It's mostly metabolic. Two different types of organization, two different roles. Now, we go back to that lady because we missed a lesion. If you look carefully, what do you see? This is the initial film. This is 2 weeks later. Look at that. It was present, but we all missed that one because we were so happy to have one. But there was a second one. It's better seen here, and several weeks later, it's even better seen. This is what occurs in any fracture healing or in many conditions. It represents the physiology of bone. Everything is summarized in that slide. And we will have it in a second, a view at the microscopic level. So what occurs for any insult, infection, tumor, fracture, even stress, there is first increased bone resorption. And that's why the fracture becomes visible. That's why we do follow-up X-ray if there is a risk for scaphoid fracture that we haven't seen. 2 weeks later, the fracture is visible due to bone resorption. And then we have extensive bone formation. Now, if we take the microscope and we focus on one trabeculi, there are many, many cells that just lie on the trabeculi, just like you here, a little bit. I know it's early in the afternoon, it's a very bad moment. But anyway, according to some insult, and here it's me who tries to wake you up, there are cells which transform to osteoclast and start resorbing bone. They make holes within the trabeculi, and later on the osteoblasts do arrive. They secrete a substance which is called the osteoid substance, and then it later calcifies. That's a process. This team of cells has a name. It's called the basic multicellular unit. In our skeleton, they are not fairly active, and it takes 10 to 15 years to completely change our skeleton. In a growing child, you need only 1 or 2 years, and the bone is completely changed because they are fairly active at that moment. Now, there is a concept, which is the total amount of bone that we have, according to the total volume, which is called the bone mass, the quantity of bone by unit of volume within these bones. During growth, the bone mass increases in everybody, and then we reach a peak value by the age of 25. So it's important to drink milk when you are a young boy or girl, but no, it's a waste of time. It will not change anything. We may drink whiskey and wine, it doesn't matter. Okay, no need for milk. The problem is that the peak bone mass is lower in female than in male. And by the age of 25, we start dying progressively, and there is a decrease in the bone mass. In female, it starts earlier and it goes faster than in men. And that's what we need to know in bone physiology and how we will understand all these conditions. Now, there is a detail. This is the quantity of bone mass. Now, we can have the same bone mass and a different input and output. If the input and output level are large, which means that the diameter is high, then there are waves in the bath. There is a high turnover. If the diameter is very limited, very little bone formation, like in our skeleton for the moment, there is not high bone turnover, there is low bone turnover. So there are 2 points, bone mass, which is a fact, and then the activity of the skeleton, which is called bone turnover. And you will have patients with the same bone mass, but with totally different bone turnover. And we'll have some example of these conditions. Now, there are many, many parameters that control all these processes. The main one is biomechanical stress. If you go to the moon, what occurs? Yes, we lose a lot of stress, therefore we lose bone. And when you come back, you are obliged to lie, otherwise you will break your bone, okay? That's the major feature. And we will see it in our practice. And this is a patient who has been amputated. This is the femur. This is not a normal femoral shaft. There is bone resorption. Look at all these lacunae within the cortical bone. That's not normal. There is significant bone resorption due to the lack of stress. The patient is not standing on that leg anymore. That's a parameter that we have to recognize on our films. Many of the other parameters, like the hormones or the interleukins or whatever, are local factors that will alter bone physiology. They are not visible for us. We can't see them. Unless that one, do you know that condition? Is that a normal bone?
So too much bone formation in the surrounding.
Yes.
The cortex is lost.
Cortex is gone away. Yes, there is not so much bone formation, but probably the cortex used to go up to here, and there is bone resorption. And that's a patient who has hyperparathyroid hormone. And you have extensive bone resorption everywhere, including in the subperiosteal area, which is specific for that condition. Who has seen that recently? A few, very few of you. So you may have a look very quick because you won't see these cases anymore because my everyday practice is not that, neither yours. So we try to focus on what we could see every day. And we focus a little bit on bone disorders. These are 3 patients. One has a normal hand, A. This is a normal second metacarpal bone. Now what about B and C? Can you describe what you see on that image? What is visible there? very thin cortex. So here we have a large cortex, which is expected, and here it's very thin, but it is white. It's normal bone. It's too thin. What about that one? Is it normal when you compare it with that one? Yes? It's not normal. How would you describe that?
Cortex seems to be a bit thickened, and it's like lobulated, so there are structures that are very dense bone and structures without dense bone.
It looks like trabecular bone in the cortex. There is bone resorption. Some people say tunneling. Okay? There is severe bone resorption, and the cortex is no more compact. It's not as white as the other one. Okay? What's the name of that disease? Osteoporosis. Osteoporosis is a disorder in which the quantity of bone is reduced. It has an official definition. It's a disease which is characterized by a decrease in bone mass, and there are some minor changes that are added to that decrease in bone mass, and these architectural changes alter the resistance of bone, and patients are prone to fracture, right? So if I have osteoporosis, do I have pain? No, I don't feel anything. If there is a fracture, I've got pain. And this is very frequent in metabolic bone disorders. If I have gout, do I have pain? No, I don't have pain. Occasionally, I may have a crisis, arthritis, and then I have pain. It's a sort of complication of that. But patients with gout may have deposits everywhere. They do not complain. They have deposits on the ears. You see them, but they don't feel anything. Okay? Most of these disorders are clinically silent, and that's a problem. Now, there are many definitions. Basically, osteoporosis is not a radiological disease. We need other criteria because we cannot assess bone mass on radiographs or CT. And there is a technique which has been validated. Therefore, osteoporosis is defined according to these criteria. There are clinical tools to detect patients at risk. We don't care about patients with osteoporosis. Many will have osteoporosis and will not break their bone. Some of these patients with more or less osteoporosis will have fractures. And the rheumatologists, the clinicians want to detect patients who will ultimately have a fracture to treat these patients and not to treat those who will not fracture because it doesn't make any sense. So it's not so easy. And there is a huge list of various conditions. They have specific or complex causes. The epidemiology of the fracture are different. But honestly, this is not extremely important for your everyday practice. So once again, quick look, then forget it. Can we see osteoporosis on our images? That's a major issue. I told you, it's a decrease in the bone mass. Which patient has osteoporosis? The one on the left or the one on the right? 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 You don't know? You want right? You think left? Why do you think right? Yeah, there is more lucency, but basically, it's the same patient, same radiographs. Never rely on lucencies. Okay, it's very bad. So when you look at a film, it's white, whoa, nice bone density. It's black, whoa, low density. We are completely wrong, and we do it, okay? So I took that example, and I hope you will apologize, but you are a very good example of everybody here. So we're all thinking the same, but no one would dare to say it. So that's great, thanks a lot. Therefore, never rely on that. You may rely on several features, but not the lucency. What about that one? Are you sure that there is osteoporosis? Why? Okay, there are two features. You're right. Two features. One, multiple fracture. So I don't see bone density, but I see the complication of that. Therefore, that elderly man has osteoporosis. Now there are subtle changes. We are taught to look at these changes, and that patient has some sort of hypertrophic weight-bearing vertical trabeculi. It occurs in some sort of male osteoporosis around 70, 80 years of age. It's not very sensitive, not very useful, but it's present when you see. You may comment on that. But definitely we can be sure that either he's got a trauma, why not? Very old trauma, but it would be very unusual to have some multiple fracture, unless in seizures. Otherwise, this is related to osteoporosis that you can get. Now, this is another patient. She has, or she had, osteoporosis. Decreased bone density, very thin weight-bearing trabeculi, multiple fracture. Are we able to detect that on MRI? Yes? Who think yes? Or no? So it's 50-50, just a few, there to answer. This is the MR, the corresponding MR. It looks totally normal. It's very important on MR imaging. We are not able to detect the bony trabeculae and the cortex. I will come back. We don't see them. We may have an idea, maybe, but it's wrong. In my practice, when I'm reporting an MR study, I never used the term osteosclerosis or osteolysis. I have no single idea. I have been so many times completely wrong when I compare with the CT that definitely I destroyed that words for my reporting when I'm facing MR. Yes?
Right, yes. I don't think so, too, but comparing all the sequences in the MRI of the spine, you can see that the bone marrow is very fatty, and then you can say there is a sign of osteoporosis, and I think I should do that.
Okay, I repeat it. He said that if you see a high signal intensity bone marrow in the spine in an elderly patient, you've got an idea that there is osteoporosis because there is an increase in fat. It is completely right, and it is completely true. Wrong. It is right in one situation. Patient with steroid. Steroid is very toxic, and we will not describe that in depth, but basically there is osteoporosis and engorgement of the medullary cavity by fat. Therefore, if you correlate signal intensity on MR with bone density, it is fantastic, it works, it's nice. But that's a unique situation, and some people have studied that and have reported that, but they had forgotten that in steroid-induced osteoporosis is not at all the same than the rest. No, basically in patients, forget it, okay? It doesn't work, never. It doesn't work. So it's very important. You have no single idea based on the MR appearance of the bone marrow. It's one of my favorite lectures, bone marrow imaging, normal, aging, and so on. There is no way. It doesn't work. Okay? Maybe you can do it depending on some sequence, but if you correlate with other methods, in general, it is not working. There are some papers, there are some measurements which are performed in research, but in this lecture, there is no research. Okay? It's pure clinical. And I have to be wrong by telling you something which is true in 95%, and I assume the fact that I may say things which are wrong. I know I'm occasionally wrong, but it's very important to be most of the time correct, okay? So I simplify everything. Should we mention bone density in our reports? X-ray, let's say X-ray or CT. You have been teaching, and I have been teaching to look at the bone, okay? But we have to keep in mind that we are not good. So, it's not sensitive, okay? Watch out for the lucency, very technique dependent. So you will formulate your opinion cautiously. In my report, I do not use the term bone density, because I use it on CT, where I know that it's denser or less dense, but not on a radiograph, because I know it's not reliable. So I will focus on bone structure. And I may say, it seems that there is osteoporosis. I'm not sure, I've got an idea. But the most important point is to describe the presence or absence of fracture. That's the main issue. We might be wrong here, but we have to be correct for the diagnosis of fracture. That's a key point in our practice. So what I usually do, I mean, without thinking of it, when I have a patient and I look at the plain films, I try to guess the age of the patient before I see it. Oh, it looks like, you know, a 65-year-old woman. Wow, she has 42. It's suspicious for osteoporosis. If it looks like 75-year-old and she's got 75-year-old, okay, no comment. Are they fractured or not? That's very important when you look at the spine. Now we go back to the last patient. We have seen osteoporosis. Which is this disease? Any idea? The bone is abnormal. The cortex has a normal thickness, but there is a change in the quality of the bone. Deficiency, but you don't see any fracture over here, not visible. There is no fracture. It's a disease, and if I show you the other bone, they do have the same appearance in the other hand as well. Paget. Paget is a very good proposal. Paget is a focal disease in which the bone turnover is increased. Okay? You have bone resorption and abnormal bone reconstruction. And in the past, I used to have Paget cases because it's a nice disease to illustrate bone metabolism. But in these patients, all the bones are like that. And there is not disorganized bone reconstruction. There is severe bone resorption, and I don't see quite a lot of bone formation. It's a systemic disease which is called Osteomalacia. Okay? Osteomalacia is a disorder, a qualitative disorder. The bone is abnormal. The bone density might be normal, but there is deficient, completely or delayed or partial defect in the mineralization of the skeleton. The osteoclasts are working, even more than in our body. The osteoblasts are working as well. They secrete the osteoid substance, but the mineralization, the arrival of the calcium and the phosphor does not occur. Therefore, the bone is abnormal. It is supple. We know chondromalacia, supple cartilage, and there is osteomalacia. The bone can be abnormal. It has another shape. In addition to that, what do we see in these patients? Bone deformity and fracture. And you've got an initial idea of this linear lucency that might represent a fracture. These cortical fractures have received in the past the name of loser zones. You all know that, basically. But how many of you have seen these lesions recently, in the last year? No. In the last 10 years? So you can delete that term as well. Although we have a lot of pollution in our brain, you know, we can delete the loser zone. But you will see these patients based on the fact that they have trabecular bone fracture. In the kids, the same disease has another name. It's called rickets. In these patients, the most active area of the skeleton is the physis. So they keep growing. They keep producing bone, but it does not mineralize. Therefore, you have enlarged physis. It's almost gone away in our population if you have patients from here. Now, there are many causes for osteomalacia. And yesterday there was a rheumatologist in the room, and I asked him, would you worry if an elderly woman has osteomalacia? And he said, no, they all have it. And we treat it without any problem, and they have no pain. So osteomalacia is extremely prevalent in the population, mainly due to the lack of sunlight exposure. So we better go out right now for the moment to increase, the capital that we have. However, in my practice, I see patients with clinically significant osteomalacia. There are many, many conditions here. One of the most prevalent in my population is patient with antiviral treatment. HIV patient with B hepatitis. They receive drugs that cause osteomalacia due to acidosis and phosphate deficiency. These patients are not rare. They survive quite well with their disease and their treatment, and they come to us with these problems. This is a coronal T1 weighted image. The question is simple. How many lesions do you see? 2, 3, at least 2. Where are the at least 2? Which one?
From the head on the right side, just below the head.
Yes.
And it's on the neck, above the tubercle minor on the
Here.
right side.
Very good. I think this might be not normal as well. And some people said, I'm not so sure, that there is a difference here. So there might be 4, 3. It's not easy, but there is one that we can recognize. The easiest one that you all could see is that one. This is basically a trabecular bone fracture, and we are back at the beginning of this lecture. This is easily seen, maybe there as well. But this is a cortical fracture. And we cannot see that quite easily in these patients. You were very acute and you saw it. But basically, I don't know how we can be sure that this is a fracture because I do not see any cortical break, cortical interruption. So the changes that are present there are not specific at all. The other one might be more specific. This is a patient, 70-year-old, male, HIV infection. He's got bilateral knee pain. Both AP radiographs. Anything to be seen over there? Not obvious. And some room, they said there might be some periosteal reaction here. Maybe. What about that one where it's bilateral, there is bone resorption, so it's not easy. There is resorption, yeah, maybe, but it's difficult. I show you the MR. Coronal T1 and fat-saturated proton density images. Okay? Now, what do you see? How do you know these are fractures?
It's the center of the fracture. You see the line is a low-density structure.
There is a line, okay, in T1 or on fat-saturated proton density image. There are lines. The question was lymphoma. Do you see any lymphoma in these patients? They made you have lymphoma. What are you missing to see lymphoma? What would you expect to see if this was lymphoma? A more geographical lesion? How would you explain the neighbor what you could see with your hands? Make a geographic lesion with your hands. I could line it out. There is a mass. How can you explain a fracture to him with your hand? One sign. A line? He said that, you know. This is the fracture. This is a mass. Okay, radiology is easy. Just translate the images with your hands. I'm not an Italian, you know, but I could try. So this is osteomalacia. It's got multiple fractures. So one fracture doesn't mean anything. Why do they have a different appearance? Here there is significant what we call bone marrow edema, low on T1, moderate decrease in signal intensity on T1, bright on T2, edema. Why no edema in that fracture? Yes? Timeline. Which is the most recent? This one would be the lower one. You might be right. It could be from this morning or long ago. Okay? I don't know. What is surprising if it's long ago, there is no callus formation. That's the signature of osteomalacia. We can't see the callus because it does not mineralize. So if you get multiple fracture of different age, that's a good sign for abnormal bone healing. And there are multiple fracture everywhere. Look at the supraacetabular fracture. This is a pubic rami fracture. These are bizarre posterior iliac wing fractures everywhere, more or less edema, different age. One condition is osteomalacia, whatever the cause. Another is patient with steroid because they have also an abnormal healing process. So if you have multiple fractures of different age, might be a suggestion, not always, of osteomalacia. This is how you will see these patients, either with an ankle MR, a knee MR, hip MR, depending on the location of the symptoms. Another patient with osteomalacia, coronal T1. Look at the significant decrease in signal intensity. Look at the terrible soft tissue mass surrounding the bone. It looks like a tumor that goes out of the bone. Although this is probably bone marrow edema, because I do not see a round lesion and I do not see a very low signal intensity. It's intermediate. This is the corresponding T2 weighted image. How do you know there is a fracture? Because of the line. The line is always parallel to the surface, perpendicular to the weight-bearing trabeculi. We'll be back to that later. This is the corresponding CT on the same day. There is slight sclerosis, but not as much as one would expect to have in a heel or a very acute chronic fracture. This is also a good sign for osteomalacia, but it's not easy because we don't do the two studies. So watch out. They have multiple fractures. Some of these may be unusual in their appearance. We have to think of that. Now, there is a final disease, which is renal osteodystrophy. There is a little bit of osteoporosis, a little bit of osteomalacia, a little bit of hyperparathyroidism, and they have multiple changes everywhere in the skeleton, not only the bones, but also the soft tissues and the cartilage. Therefore, they have what we call a high turnover, significant tunneling of the cortex. They have destructive arthropathies in some joints. They have significant soft tissue calcification, multiple fracture, and so on. This is an umbrella term that covers many, many different conditions. They may have amyloidosis. They may have aluminum toxicity, a lot of things. Don't forget, don't care about that. Renal osteodystrophy, complex bone change, diffuse bone changes, right? So to summarize what we have seen so far, we know the difference between trabecular and compact bone. We know about the work of the basic multicellular unit, and we know how it translates on the radiographs of the CT. We will remember the concept of bone mass and the changes with age, and this will induce several conditions. Now, we have to focus on fracture. We have already seen some of these. Now, we go into detail in the semiology of these fractures. This is the different types of fracture that we see in our practice, and you have to fill in the different areas here. So they have some names. What is the most frequent pattern of fracture? If you went skiing this morning, traumatic. In traumatic fracture, we have a normal bone resistance, but there is an external force, an accident, a fall, whatever. There is therefore a clinical history. I have been skiing today and I broke my tibia. These are the characteristics of post-traumatic fracture, not too difficult to recognize, although occasionally it's a problem. Which other sort do we have? Pathological fracture. In this fracture, there is no history of trauma, but there is normal stress on the bone, but there is focal weakening of the bone, generally due to osteolysis. Then we have a fracture, okay? And there are two other fractures, which are the fatigue and insufficiency fracture. So the two, fatigue and insufficiency, are called the stress fracture, okay? And in the fatigue stress fracture, there is increased repetitive overload. It's not acute. It is either by sports activity or professional activity. You repeat the same movement, the same stress on the bone, very little amount of stress, but which is repeated over weeks, over months, and by the end, there is a fracture. In these patients, therefore, we have an abnormal stress which apply on a normal bone, and you may have a clinical information which might indicate that, the sports or the professional activity, most of the time. In the insufficiency fracture, the bone stress is normal. It is the normal activity that creates the fracture because there is a systemic diffuse, decrease in bone strength. It is diffuse. In these patients, there is no clinical clue. The diagnosis may be unexpected. Imaging has a role to play. Nobody is aware of that old lady who doesn't seem to have any problem and has got back or chest pain while working. It's normal stress, normal activity, and it breaks the bone. And then you've got the pathological fracture. What is visible on that CT? It's a woman and she's got acute pain. What do you see? It's simple. Yes, a fracture. How do you know it's a fracture? What do you see? It's very important to start from the image, describe the image, and then you may give the name. But we have to do it again, otherwise we, just reflex. And we forget our reflex, even if they are good. What is abnormal? A loss of height. I've been told to look at the shape of the bone. It's abnormal shape. It's abnormal loss of height. This is a fracture, correct. On MR, what will you see? Yeah? Bone marrow edema. And this is the corresponding T1. So on CT and on radiograph, what we see is abnormal shape. Cortical interruption, displacement, angulation, translation, whatever. On MR, the most striking feature is marrow changes. Can we see them on CT? This is a monoenergetic CT. I can't see bone marrow edema over there. Forget it, okay? On MR, is the shape abnormal? Yes, it is, if you look carefully, okay? But it's not so evident than on the CT. So the first point is, wow, there is significant marrow change. Why not a metastasis or a lymphoma? What is suggestive of a fracture? What would you expect to see if there was a lymphoma, a myeloma, or whatever? A mass. Do we see a round mass over here? No, what we see is a band-like pattern in which we have a region, a transverse region, rather well delimited, of abnormal signal intensity. Which sequence do we need to make sure this is a fracture? We see the abnormal shape. What would we need to go a little bit further with MR? Fat suppress, or at least a fluid-sensitive sequence. And I have a standard T2 weighted image. What is specific for the fracture in that T2 weighted image? What do you see? Oh, sorry, these are the multiple. I changed this morning, so I forget. Usually I don't need to look at the slides anymore. So this is the T2. What do you see there? High signal. Is it specific for a fracture? With the low density band, we see the line, the impaction fracture, which is located perpendicular to the weight-bearing trabeculi, perpendicular to the forces, because there are not so many weight-bearing trabeculi in that patient, perpendicular to the surface, parallel to the articular surface. That's typical of an insufficiency stress fracture without any underlying focal lesion. Now, as a rule, these fractures do heal in about 3 months, 3 to 6 months, based on T1 weighted images. And this is the same patient 3 months later. The abnormal shape is still present, might be some subtle changes, but basically the vast majority of the marrow changes on T1 are gone away by 3 months of time. Yes?
Why did you do the MRI in the first place?
Because I know, but it's only for teaching purposes. She was working, she was an elderly woman working in our institution. She was going on holiday, she took a suitcase, she had acute back pain, so she came directly with that to us, and she did the MR because she knew that was fantastic, because she used to bring the patient to us, okay? And you have to be kind with these people as well. And then I asked her to do the CT for teaching purpose. Most of the teaching cases are derived from stupid prescriptions. You know, it's very, very important to keep an eye on that. It's very important. So this is a follow-up. That's how we had the follow-up as well. I asked her to do it again 3 months later. And this is the change that we could see. Okay? This is the basic change that are visible on MR. It's another patient. There is no trabeculi, so here we see more fat, as you said. And here the fat is a little bit gone away, maybe bone marrow edema, but it's more strying on T1. On T2, it reverts to normal. And on T1, after contrast injection and fat, it returns to normal. Okay? Will you use fat suppression if you inject contrast? Well, the radiologist and I do, we hate to see lesions disappearing. We like to see the lesion once, twice, 3 times, 4 times, and we hate this. However, the disappearance of the marrow abnormality on T1 with fat after contrast is the best sequence to suggest a benign fracture. If you do fat suppression, and this is another one in whom I did several images, we have the stir sequence, okay? You have low signal intensity or variable intensity in these vertebral bodies. It converts to high signal intensity, and you have the line over here. If you use fat-saturated T1 weighted images, you basically have the same information than on the stir. The lesion does not disappear. Ooh, I'm good. No, this is more important to define a benign fracture. Okay, but I use fat suppression, but I know when I use fat suppression or when I don't. And I know what I do, because it took me 15 years to understand and know it works. Okay, in this situation, no fat suppression. You may, but this is not specific. Even a metastasis can look like that. And there are in the literature several papers. Most of these say fat suppression. Gadolinium does not help to make the diagnosis, but these are papers from the last 15 years with fat suppression. The previous one that nobody reads anymore, they said it works fairly well and that's the best sign, but these were papers based on standard Spinnaker T1 weighted images. So even if we change work, it's not always better. It makes things more complex, okay? Now, to summarize all that, the MR feature, which is specific for a trabecular fracture, is A, osteoporosis. Do we agree? Is that specific for trabecular fracture? Osteoporosis on MR? No, we don't see it on MR. Marrow edema, is that specific? Neither. Low signal intensity line or bands on T1? Yeah, we have seen some of these. And on T2? Yeah. And we never know on which sequence it will be best depicted. T1, T2, fat, SAT, post-GAT. We cannot predict. But once you have seen it, it's all right. This is a specimen, a fracture of a vertebral body. Look at this abnormal shape, and you've got a linear area of sclerosis. This is callus formation. This is the fracture. You can see it on MR. Here is the fracture line on T1 and on fat suppressed sequence. If you look at the histology, here at the vertebral plateau and the disc, a normal marrow or roughly normal, and then you've got the callus. The fracture is always perpendicular to the foracis, parallel to the surface of the joint, and frequently located at 1, 2, 3 millimeters below the articular surface. Nobody knows why, but that's quite frequent. Another patient, right hip pain, coronal T1. She's quite young, and would you consider that these two arrows, these two lesions, are a normal variance? Who thinks it's a normal variance? Nobody? Good, great. We should not see that in a normal patient. Could that be femoroacetabular impingement syndrome? No. If you believe in that, it's located somewhere laterally. Could that be multiple myeloma? Why not? Why not? However, it would be very unusual to have 2 lesions symmetrical and nothing elsewhere. Makes no sense, but why not? So the answer is, I don't know. T1 is not specific. It's like a hot spot on bone scan. It's not specific. It tells you something wrong. What do we need to know what it is? T2. And this is the corresponding fat-saturated terminate weighted image. It converts to high signal intensity. This is edema. What's in the middle of that edema? The line. Okay? These are bilateral insufficiency stress fracture of the trabecular bone in a patient with renal transplant. forget it, okay? It's another cause for altered bone metabolism. But the most important point is to note that the line, basically, is formed by the juxtaposition of nodules. And although this is another level that we cannot see on MR, this is, according to the literature, a trabeculi which has been broken and around which there is callus formation. Another patient, metaphyseal bilateral abnormality. What do we need? T2. Which plane? Coronal again, or sagittal, or transverse. The resident who was sitting next to me said, let's do transverse. I said, okay, let's do it for the lecture. And this is the transverse image. Although it converts to bright signal intensity, you do not see the fracture. Never forget, these are planes. If the imaging plane is in the plane of the fracture, you will not see the fracture. And as you asked it, I did it. And as I knew that you would prefer the fat saturation, I gave it to you, but basically, these are rather similar. T2 or fat saturated. Once again, you see the different nodules hanging on the trabeculi. A friend of mine, surgeon, operated that patient. I still don't know why, and he threw away the specimen in the garbage. So I went in the operating theater, and I took it out, and I put it to the MR. There are lesions over there. I knew the patient. I knew it was quite interesting. How many lesions do we see on that coronal T1? 2. One is a old fracture. However, is it parallel to the subchondral bone plate? No, this is not parallel. This is perpendicular. That's perpendicular. That's parallel. Is it close to the subchondral bone plate? No, it is at some distance from the subchondral bone plate. Any other diagnosis? A vascular necrosis. And this is the corresponding section where you see this fat-containing necrotic tissue and the surrounding interface. There are lines. They usually delineate an area, and they are not always parallel to the surface. They reach the surface at some areas. Okay? That's osteonecrosis. What about that one? Well, it's difficult to tell. We need the T2. Here are the T2. Bone marrow, edema, and once again, fracture. Fracture line, a zigzag line, nothing to be seen on the X-ray. Probably an acute or rather acute fracture. This is the histology where you see multiple dots, which are callus formation. If you take one trabecula, you see the fracture line. It's broken. It's an oblique fracture, compression fracture of the trabecula. It slides on the other one, and then you've got callus formation. That's the elementary basic lesion in cancellous or trabecular bone fracture. They add on the plane that forms the fracture line. CT of a patient with ankle pain. Nothing to be seen. There is bone marrow edema. If you wait 3 months, look at these small nodules hanging on the trabeculi. They align on a plane. You've got extensive periosteal reaction. Insufficiency stress fracture of the trabecular bone. They involve the spine, the thoracolumbar spine, and the metaphysis of the lower limb bone. You will never see a shoulder MR in my lecture. There's no fracture due to osteoporosis or after a fall. Typical appearance on plain films, nothing to be seen at the beginning. Then you have faint, ill-delimited sclerosis that later on will disappear with a little bit of periosteal reaction. Typical appearance on plain film. This is a woman. She's doing a lot of sports. She has very low BMI. She's got ankle pain. Anything to see on that plain film? Soft tissue. There is something wrong in the soft tissue. What's wrong over there? Yes? It's too dense. Let's assume that once we may say it, it's too dense. Or, what's going away? The Kager's fat, the fat plane which is here, or the subcutaneous fat is going away. What is that disease? No fat anymore. This is anorexia nervosa. And some patients with fairly active, this is called the athlete triad, amenorrhea, osteoporosis, and anorexia nervosa. Fat is going away on MR. We'll have this. This is the sagittal T1 weighted image. At first glance, you have the feeling that the machine is broken. Then no, it's not broken, but the technician has forgotten to take out fat suppression. No, this is a standard spin echo T1 weighted image. And everywhere it's grayish on T1. That's serous marrow atrophy or gelatinous transformation. No fat anymore. It's just hyaluronic acid everywhere. Okay? On T2, there is increase in fluid. It's bright on T2, and here it goes. The fracture of something which might, we know the fracture is there, and although we're not sure, we had a plain film later on, and we could see some callus formation later on. This is serous atrophy in patients with anorexia nervosa and many metabolic bone disorders, and in patients with cancer-associated cachexia. This is a patient with anorexia nervosa. Standard sagittal T1 weighted image. No fat anymore. It's strictly the same signal pattern than a sagittal T1 weighted image with fat saturation in a patient with fat. Exactly the same bizarre appearance of the cartilage, bright on T1, but the water still has a low signal intensity. Grayish everywhere. Anorexia nervosa. It's very labile. A few kilograms later, she come back. And then you've got a normal signal intensity. It's reversible, depending on the energetic status of these patients. She is 20 years old. Look at the spine. It looks like women of 65. Although I see no significant definite fracture. Maybe there, it's a little bit flattened, so why not a whole fracture? She's got ankle pain. Do you see anything? Very subtle, yes? Yeah, and it obeys to the rule. It is perpendicular to the weight-bearing trabeculi, not too far from the cortex. I show you the MR, T1, nothing to be seen. The signal is a little bit bizarre, and this is probably some mild form of serous atrophy. Shows bright signal, and here is the line on T2. Another patient, and I apologize for all the women who are here, but metabolic bone disease is really sex-related. She was pregnant. During the last trimester, she had back pain, pelvic pain, and hip pain. And we are 5 days after delivery. You can see there is still a little bit of pubic diastasis. Any problem in the hip? Yeah. Left femoral head is abnormal. How would you describe that? Yes. So he said two very important things. There is a difference in density. I do agree with him. He is right. But I always feel not confident looking at the density. I look at the trabeculi. It's not easy. They're probably going away. But we all know that even 50% of the trabeculi are going away. It's not visible on the plain film. But he said something which is very, very important to focus on. He said the cortex is inconsistent. It fades away. If you compare with the other side, the line is here, the line is going away. I don't see it clearly. The joint space is normal, but the cortex is going away. This is called transient osteoporosis. At this moment, we may just say this is osteoporosis, regional osteoporosis, because we don't know whether it's transient or not. How would be the MR? Edema, and this is the T1, T2, edema. If you look carefully, and these are sagittal T1, fat sat T2 weighted images, where is the line? Have you seen the line? It is parallel to the articular surface, near to the articular surface. It does not completely delineate an area of the epiphysis. This is the insufficiency fracture. Will that patient heal? Yes, she will, and I will show you that. But if you go in the back, you keep looking back, she had back pain. Look at the sacrum. What's wrong over there? Does she have ankylosing spondylitis as well? Why not? There is an area of high signal intensity, T1 and T2, and an area of bone marrow edema. Another image. Significant marrow infiltration on one side, and it's bright on the other side. What's your diagnosis? Yes, here. Fatty marrow on the left side. And why not say these are the two same conditions? Could be. How do you know there is a fracture here? There is a line on T2. I have some doubt about this. Maybe. If you look here, I have some doubt about that. Anyway, she came back later, 3 months later. Look at the hip. It's normal. Look at the sacrum. Now we have fat on both sides. And this is a frequent condition in the bone marrow when there is a condition which heals, an infection, a tumor, fracture in red marrow. Usually the red marrow does not completely comes back and there is more fat and there is a high signal intensity area. Visible in red marrow, not visible where one should see fatty marrow. Now, sacral insufficiency fracture are quite frequent. They are frequently bilateral. This is an elderly woman with radiation therapy, risk factor for this fracture. The diagnosis is difficult. They are seen by oncologic patients. They have chronic back pain. It starts slowly, more on the right. A few weeks later, more on the left. They have pain, difficulty in working. It's not always easy. Here we have the line, we've got edema. The line in this case is better seen on T1. On the other side, there is no line to be seen. And that's quite frequent as well. The line is not always present. Nobody knows why. We have lines or we don't. Why we see them on T1, on T2, on fat sat, on post-GAD, nobody knows why. But when it's seen, you may feel more comfortable. Now, MR went back to normal, X-ray went back to normal. We have seen fracture within the metaphysis of the lower limb. They are fracture in the epiphysis as well, although this was not admitted 25 years ago. This is a woman with refractory hip pain, and she had what I would consider to be insufficiency fracture. She had to take care of her man, so she was operated with total hip replacement that she could walk again. So we had the specimen, and if you look at micro CT imaging of these lesions, here is the subchondral bone plate with the cartilage, and here are the fracture, and these are small areas of callus formation. Histology with the fracture, callus formation everywhere. And if you look at the surface by using volume rendering software, this is the software, the surface of a normal femur head, and this is the one with the fracture. And you see the faint line, very subtle, on the surface, on the bone. And for those who are interested, look at the porosity of the cortical bone. It's fantastic. It's totally different. Two different patients, same age. This is totally different. Nobody knows why, but it's quite an interesting field of research. Now, to summarize, we have seen the stress insufficiency fracture of the trabecular bone, thoracolumbar spine, metaphysis of the lower limb, occasionally the epiphysis. They do heal in the vast majority. We switch. This is another patient, right thigh pain. What is abnormal here? On T1, on T2. Low on T1, rather ill-delimited. High on T2. Any idea? That could be many things. Osteomalacia, why not? Metastasis, lymphoma, why not? We need more. I give you more T1 weight. The X-rays were unremarkable. Multiple coronal T1. Anything wrong? Where? At the lower trochanter, here. Yeah, we're right. Here is the fracture line on T2 and here. So the bizarre shape is due to the bizarre shape of the fracture. How can you better see this fracture than on MR? CT. I have shown you fracture of the metaphyseal bone, on which CT was nothing to be seen. Here, we want to look at the CT. And this is the CT. What do you see? Bone marrow edema. Okay, but we know there is bone marrow edema. What's wrong with my CT? Nothing. Marrow change. What do we need? Coronal or just the X-ray was normal. It was just a bone window. I know this is stupid, but these fractures are not easy to detect. So we have to look at these images in the good condition. And this is a sagittal reformat. And this is the elementary change that you will see. Cortical interruption and subperiosteal endosteal callus formation. And that's the fracture. Very useful in my practice, MIP reformat, maximum intensity projection, where you can see the shape, the extent of the fracture. The patient was not treated. What did occur? It slided, and he came in 1 month later with the fracture. So these are the complications of this fracture. Displacement, very important. Another patient, swelling of the leg on one side. They all have a normal Doppler ultrasound because it's the first diagnosis. This is not rare. Not significant bone change on the plane film, but it's hot on the bone scintigram that we used to do in the past. We do now MR. And this is subcutaneous edema and medullary edema. Axial T1, axial fat saturated. Do you see any fracture line? Remember the patient with Osteomalacia and the cortical fracture. Very difficult on MR. What do we need? CT. Here it is. Now, once you have seen the fracture on CT, yes, it's there. But it is not recognizable as such. So we recognize trabecular fracture based on the line. The cortical fractures are difficult to recognize because we cannot see the cortical interruption. These fractures may be longitudinal as well. You will have that in your practice. It's how they present. If you do not pay attention, you will miss the diagnosis, even on axial images. You never know the diagnosis, the clinician either. They send the patient, just find something for me, please, she's got pain. So we use the body coil, lower resolution, comparative because we don't know where we are. We use stir sequence in many planes. We just see edema. If there is edema in the subcutaneous plane and in the medullary cavity, what is in between? The cortex. You have to think of the cortex. Therefore, you think of CT if you cannot find it on MR. And it's difficult to see that on MR. Though these cortical fractures are rare, the problem is that they may displace. This is another, typically the patient that I see in my everyday practice. Elderly man, many different conditions, chronic renal insufficiency, dialysis, many drugs, pain on the left side, nothing on the plane film. MR. Once again, the same marrow change that we have seen before. They all present like that. I just don't know. But you've got a huge marrow change in typically that region. My opinion, it's where fluid collects within the diaphyseal cavity. On T2, almost, bizarre marrow changes. On axial images, you can confirm that probably this is not completely within the marrow cavity, but it's also a little bit outside. Where is the fracture? Not recognizable. If you believe this is the fracture, maybe, but why does it go out? Makes no sense. CT, coronal reformat. Difficult, maybe. We were happy because we did a bone scintigram. So we knew that this might be the fracture. It's not easy. They are not displaced. If you look carefully on axial images, you will see, comparing with the other side, otherwise you will miss it. You will see the fracture. This is the MIP reformat where you see the fracture. The patient was advised to decrease weight on his right femur, on the left femur. What did occur? He came back 1 month later. Fracture on the other side. These elderly patients have a dynamic bone. It's inert. It does not move. For any reason, they can explode, and get huge fracture. very complex, extremely non-specific. Maybe this nodular appearance could be the fracture. It's an area where many fluid collection can accumulate. There is fat around it. Now, there is a specific situation in which there are numerous cortical fracture. These are the patient with bisphosphonate therapy. The previous patient did not have that drug. Okay, so you can have a cortical fracture without any specific drugs. But this one is crazy. It causes this kind of fracture. Transverse, partial, not complete fracture of the shaft of the femur, usually located on the lateral aspect or the anterior aspect. They are incomplete fracture with healing callus formation. And this is some sort of big formation that tells you that this is a chronic process. These patients have bone which is intoxicated by the product. They are treated for osteoporosis, and these drugs are extremely efficient. But in some patients, they cause fracture. They cause these unusual fracture. And they are frequent because these patients are all treated nowadays in Europe with these drugs. In the literature, you will see these kind of changes, which basically are not recognizable as a fracture. It's very difficult on MR and on plain film, but they occur in typical area. In my practice, this is how they appear. That lady had left pain, thigh pain. First, CT of the lumbar spine, because we thought it was coming from there. She had multiple infiltration, which did not, enhance the problem. She went back for ultrasound of the hip. We had the plain film on the hip, and 1 month later, she came with a fracture. We missed it. It was there at the border of the film. It's not recognizable, but it's crazy. Why is it important? It's important to recognize even when it's broken, because you've got that angulation. You have to think of bisphosphonate treatment, because these fractures are frequently bilateral. And if you look on the other side over here, there is slight minor changes. In the US, they tend to treat these fractures before they break by putting a nail in the femoral shaft. We don't do that in Europe, in most of the country, but these patients are at risk for fracture. Another one, non-significant cortical change at the emergency department. Few weeks later, she came back with the fracture. Very difficult. These fractures are difficult to treat. Non-union is frequent in that region, very difficult. Now, there is a normal variant you have to be aware of. In many young patients, you will see some cortical irregularity. It's not dense. There is no lucency. It is a change in the shape of the bone due to tendon insertion in that area, which is a normal variant. There is no linear lucency. There is no cortical thickening. It is thin cortex. Now, you have seen that these fractures have some complication. It is displacement of the fracture. And I show you one woman with an insufficiency stress fracture of the medial condyle. And this is her coronal CT arthrogram that we frequently do in our institution. There is bone sclerosis. As you have seen on the cases, this is consistent with some callus formation, and we've got extensive edema in the bone marrow and fat-saturated images with slight thickening of adjacent to the subchondral bone plate. On the different images, you have similar changes, and these are called stress insufficiency fracture of the medial condyle. The vast majority of these fractures heal. Unfortunately, in that patient, it did not heal, and 6 months later, there is cortical displacement, abnormal shape. The bone marrow changes have decreased, but there is cystic changes. There are changes that indicate that there is displacement of the fracture. And these lesions have received the name of spontaneous osteonecrosis of the knee in the past. Nowadays, we all agree on the fact that the vast majority of these spontaneous collapse of the epiphysis are related to a pre-existing stress insufficiency fracture of that part of the bone. It is located not in the metaphysis, it is located in the epiphysis. And there, if there is a break, it does not heal because there is persistent micromobility. On the coronal image, this will be stress fracture. At that moment, that becomes spontaneous osteonecrosis. Another case of spontaneous osteonecrosis of the hip. She's got collapse, significant deformity of the knee. There is no chronic osteoarthritis. It is a significant focal change. This is a fracture. Basically, it has received the name of osteonecrosis because it's a spontaneous fracture, and in the past it was admitted that all spontaneous fracture in an epiphysis were related to an underlying necrotic tissue. Therefore, it was osteonecrosis. If you look at the MR, you've got a thick, low signal intensity area, which is suggestive of osteonecrosis. It can occur anywhere. This is a patient with B hepatitis treated with adenofovir, which has got hypophosphatemia. It's got bilateral hip pain and everywhere muscle pain, which is frequent in osteomalacia. Look at the left hip. We have edema up to the subchondral bone plate, which is round. The sphericity of that epiphysis is normal. 3 months later, the patient is healed. No symptoms on the left side. No specific treatment. Now, have a look on the right side. If you look at the sagittal T1 and fat-saturated image, what's going wrong there? Similar, more extensive marrow changes and abnormal shape. There is flattening of the epiphysis, buckling anteriorly, and there are subchondral changes with cystic change. 3 months later, the fracture is even more obvious here anteriorly, very small, but clearly present. This will never heal. Spontaneous epiphyseal fracture, we would have called that spontaneous osteonecrosis of the hip. Nowadays, I would call that pseudoarthrosis, non-union. That will progress to further collapse. I still use the term of osteonecrosis, but it's still debated. So there are similar conditions. Now, this is the last patient. He's got pain. And at the emergency department, they were not certain that there was a fracture of that vertebral body. Maybe a little bit of buckling anteriorly. It's concave over here, maybe a little bit convex anteriorly. Why not an early fracture? So he's got a CT. On the CT, you've got the fracture, the abnormal shape of the vertebral end plate, and on the coronal reformat, you've got the fracture within that vertebral body. Spontaneous insufficiency fracture of L1 or L2. In the vast majority, these fractures heal. I've shown you that. Occasionally, it does not heal. 7 months later, here is the fracture. How would you call that? There is significant collapse, and there is a cleft. And all the radiologists know that if they see a loosened cleft, it is osteonecrosis, and this was called vertebral osteonecrosis or Kummel's disease in the past. It is most likely that these are complicated insufficiency fracture, just like in the femoral head, just like in the femoral condyle, the talus, or the metatarsal head. They may not heal. They may progress to non-union pseudoarthrosis, and by the end, osteoarthrosis. This is another patient, same day. Sagittal CT, vacuum within the vertebral body. Very bizarre changes on T1 and on T2. Where is the vacuum on that patient? A few minutes later. It's gone away. You don't see it on the X-ray. It's just collapse. How can you explain that? A last thought. Upright and lying. Here the patient is lying. It opens. If he stands, it closes. There is huge mobility. It is unstable. This is pseudoarthrosis or osteonecrosis, if you like. The most important point is to remind that this fracture may lead to spinal cord compression, which is not yet the case in this patient. But these are spontaneous, benign fractures that can cause spinal cord compression. Normally, if you have a benign fracture and cord compression, it means metastasis or an underlying condition. We know that. Exception, spontaneous vertebral collapse that do not heal may lead to spinal cord compression. So to summarize, we have seen some metabolic bone disease, and we have left aside all the other conditions. There's much more to learn. These share a long clinically silent, and we play little role in the detection of the disease. The role that we have to play is the detection and characterization of the complication of these conditions, which is spontaneous insufficiency fracture. The vast majority of these lesions involve the trabecular bone. The vast majority of these lesions do heal. Occasionally they don't heal when they are near articular surfaces, in the spine, in the hip, in the knee, and these have been called spontaneous osteonecrosis because of the collapse and the vacuum phenomenon that is related to persistent micromobility. Insufficiency stress fracture of the cortex, totally different. Difficult to make a diagnosis with MR, but you will pick up the bone marrow change and the soft tissue change. You have to be alert about these lesions because they may displace quite frequently in the femur, and it's important to treat early this patient before any displacement. That's extremely important, but it's really a challenge in your practice. Watch out for all the elderly patients. It's very common. Thanks for your help during this lecture, and I wish you a nice afternoon. Thank you.